I am Joy Taylor, Program Coordinator at AHEC West, and I'd like to thank you for joining us today for a wonderful presentation on COVID-19 updates, hidden health risks of social isolation in later life, and pathways to a more connected future. We have a stellar panel of speakers today. Ms. Bernice Hutchinson, the Deputy Secretary of the Maryland Department of Aging, Dr. Wilbur Chen from the University of Maryland School of Medicine, and Dr. Thomas Cudjoe from the Johns Hopkins School of Medicine. I'd like to give a big shout out to Garrett County Orthopedics for their sponsorship of today's program. That's Dr. Alvarez, Dr. Feathers, Dr. Park, and Dr. Fridkin. Some housekeeping information. We will have a few minutes at the end of each presentation to respond to questions from you. Please put your questions in the chat box, and we will do our best to answer them at the end of each session. If we have a need to follow up afterwards with any questions that we ran out of time to answer, we'll do that by email. There is a 10-minute break scheduled about halfway through. There will also be an evaluation tool sent to you at the conclusion of today's program. Please complete that. It is necessary for certificates to be distributed, but as importantly, we use it as a planning tool for bringing your interests in topics and speakers for future events. Slides and other resources will be made available to you at the conclusion of the presentation by email. I'd also like to now introduce Dr. Diane Martin, the Director of the Geriatric and Gerontology Education and Research Program, otherwise known as GGEAR, at the University of Maryland, Baltimore, who provides resources and guidance to us in bringing high-quality training at reduced costs to our healthcare professionals and health professions students. She will be moderating our conference today. Diane, thank you so much for joining us.
Thank you, and thank you everyone for joining us this morning. Welcome to the second in a series of 3 conferences that we have focused on the impact of COVID on older adults. COVID has affected all of us. It's caused us to change the way that we work, the way that we learn, and the way that we are living our lives. But no group has been more affected by COVID than the older adult population. Over the next 3 hours, you'll learn more about efforts across the state to reach older adults who may have become isolated as a result of COVID, and other services that are available through the Maryland Department of Aging. You'll learn about efforts in the medical community with regard to vaccine development and delivery, and we'll also have a discussion on the importance of remaining socially connected while physically distanced. We hope that you leave here today with a renewed sense of optimism about the future and the positive impact that you can have in the lives of older adults. Across the state, nearly 20% of Maryland's approximately 6 million residents are aged 60 and older, and it is the fastest growing segment of the population. And within that cohort, the age 80 plus is really the fastest growing, and that is the group that's been most affected by COVID, right? It's had the most significant impact. As you may know, nearly 8 out of 10 deaths from COVID have been older adults. A large proportion of vulnerable older adults do live in our more rural areas of the county, of the state, including Western Maryland, which is the region served by AHEC West and is the host of this conference. In addition to being older, more than 8% of Western Maryland older adults living in Garrett and Allegheny counties live in poverty and are in need of resources beyond social connections. Therefore, we're really pleased this morning to have join us Ms. Bernice Hutchinson, who will discuss services and resources available to older adult residents in this part of the state, as well as across the entire state of Maryland. Deputy Secretary Hutchinson has the important role of leading day-to-day operations for the Department of Aging and developing strategic partnerships, fostering coordinated statewide delivery of essential services across the state. Welcome, Deputy Secretary Hutchinson.
I thank you so much, and good morning, everyone. I appreciate this opportunity to come to you today with an update on the Department of Aging's efforts to address isolation, and particularly during this time of COVID. Now, while advancing age is not synonymous with isolation, isolation and advancing age are more often than not found sharing the same space. Living alone, the loss of a spouse, the infrequent social contacts a person may have, the long distance proximity to family, lack of relationships, and the disconnection with younger generations are just a few of the reasons for isolation in later life. Our department has grappled with the challenge of isolation and older adults for decades, as have departments of aging across the nation. The COVID-19 pandemic has given us a new sense of purpose and an urgency to reimagine this challenge of isolation and older adults. Lisa, let's move to the first slide. What you see here is a graphic that represents how the Department of Aging envisions its work today. We see older adults at the core of our approach to providing person-centered solutions to support independence. Notice here that the person is at the center and that the services surround the individual. There's a range of opportunities here for the 60+ population, touching all ethnicities, all abilities, and all incomes. I'd like to provide an update for you this morning on some of our current efforts here at the department. I'll start with innovative initiatives that not only help us to modernize our program offerings in the department, but have also helped us to address isolation brought on by COVID. I'll end with how our tried and true federal and state programs, which can be found in every state across the nation, and many that have been in place since 1965, continue to provide a strong foundation for the department's mission and work. The next slide, please. Senior Call Check. Senior Call Check is a daily automated call. It's free of charge. Anyone in the state of Maryland, 65 and older, can register for this service. It's a check-in service to verify a person's well-being, and it includes a daily message helping the participant to keep up and be informed of breaking news on topics such as fraud, COVID, or vaccines, for example. The service has a built-in safety net, and by that I mean if the participant does not respond, then an identified emergency contact is called. If that contact does not respond, then a non-emergency number is called to ensure the safety of the participant. During the pandemic, we have added an option for weekly conversations at the request of the participant. We call this Senior Call Check Live. Senior Call Check Live engages the participants with a volunteer once a week to discuss whatever the participant desires. We found this to be helpful for stimulating engagement and also to support the need for additional services and even prevent unfortunate challenges in the home. If you'd like more details on Senior Call Check and Senior Call Check Live, please check in on our website, where you'll find a video, downloadable materials, and registration procedures. Simply go to our website, and we are always looking for volunteers to join us to make the Call Check Live calls and engage with our participants. Next slide, Lisa. Caregiver Services Corps. Our department became concerned at the beginning of the pandemic. Because there are so many people giving care to families and neighbors, what would happen if a caregiver was exposed to COVID or went down with an illness? We wanted to prevent unnecessary calls to 911 and unnecessary visits to the emergency room for older adults left without a caregiver. Anyone expressing concerns in caregiving crisis can simply contact our multilingual 24/7 call center. This call center will analyze the need and determine the set of skills needed for a temporary immediate caregiver. We use the Maryland Medical Reserve database. This is how we get our volunteers. And we seek to match that person, that volunteer, with the individual in proximity to where the person lives. The Department of Aging makes that connection and arranges for the match. This is a temporary service, but it can provide a range of supports that help to stave off hospitalization or the need for more costly interventions on a temporary basis. Assistance like getting out of bed, attention to activities of daily living, ADLs, meal prep, and picking up groceries. Now, we don't want you to confuse this with a chore service or an in-home supportive service. It is not that, and that's not the purpose of the service. The Caregiver Services Corps is a temporary gap filler. It's an emergency service. We're proud to say that Maryland is the only state in the nation to offer this type of service. We're the first, but we certainly don't think we'll be the last. To learn more, get the entire story of this new and exciting opportunity that we're offering, check on our website. Lisa, next slide. Communities for Life. The goal of this particular innovation is to prevent isolation. It's framed on the concept of a service navigator who is actually a bridge and a connector to services and supports. This service allows people to remain in their homes, learn about services, and to connect to information and supports that they need. There is a membership fee. The services are covered by a nonprofit organization. And the program is truly intended for people in the middle income range. And here's why. States across the nation are grappling with the dilemma of increasing older adult population, the escalating cost of Medicaid, and the limited resources to support the burgeoning spend down population. Take people who have the ability to care for themselves and to present things that may happen that lead to a higher level of care and costly medical expenses and even nursing home admission and the spend down into poverty and Medicaid. We want to support these states' efforts to control the Medicaid spending and to keep people in their homes for as long as they desire to be there. We train the service navigators to expose their clients to information and services such as falls prevention classes, how to reduce fraud by recommending vetted contractors, how to avoid isolation through regular contact with the navigators. We help them to join classes, book clubs, and possibly even a golf foursome. Navigators are trained to detect isolation and depression and can make those first steps to supports in those areas. Avoiding isolation, preventing higher levels of care, keeping older adults safe are our main goals. This program is now offered in 10 jurisdictions throughout our state. Nearly 50% of our state has some presence with this program, and we are growing. Maryland, again, is the only state in the nation working to change the trajectory of aging in this way. Instead of a fall from good health to hospital, to nursing home, to spend down, Medicaid, and ultimately poverty, This program supports maintaining a vibrant and thriving middle-income resident at home in a safe and meaningful way. I invite you to go to the website for the full story and to learn how we're growing. And finally, on our innovations, next slide, Lisa, the Durable Medical Equipment Program. Have you ever wondered what happens to a wheelchair or a hospital bed when it is no longer needed? Well, we certainly did at our department. We thought about this and we were inspired to create the Durable Medical Equipment Program. It's free for anyone who needs mobility equipment. There's no waiting list. Any person of any age can use this service. Donations of equipment are accepted. Now, here's the process. First, we adhere to a national standard for cleaning equipment when it is received. All equipment is immediately addressed with a thorough cleaning. We use certified people to repair donated equipment to ensure it is safe and ready for use. This is a great program for people who do not have insurance, but you might also see the value of this program for people who do have insurance. It could possibly cut down on the wait time as an interim solution is in process for insurance coverage, waiting for approval, and even waiting for prescriptions to be filled. The warehouse currently stores walkers, rollators, wheelchairs, hospital beds, and more. These are all donations from individuals, hospitals, nursing homes, for example. And here's the key. We are not a lending service. We are a giveaway. One of the great benefits of the program we found is the environmental impact on Maryland. Our warehouse is now stocked with 37,000 tons of equipment. We're saving landfills. What may have been dumped is now being cleaned, serviced, and ready for use, free of charge to anyone who needs it. We'll open our warehouse doors soon to the public, and we envision that these pieces of equipment may help people to reimagine their independence, their ability to engage and reduce isolation through the use of walkers, electric wheelchairs, and more. Even during the period of COVID, someone who may have difficulty getting from a bedroom to a bathroom or to move about their space with more confidence, this program can be a great help. We know that once we are beyond and on the other side of COVID, this program will open fresh new doors for people who want to go outside and engage in a whole new way. So again, go to our website, learn all about it, and follow us on the Department of Aging's Facebook page for the grand opening for this exciting and new program. All right, Lisa, next slide. I wanted to just spend just a moment on what I call the bread and butter. These are our federal aging network programs. Many of these programs have been around since the Older Americans Act of 1965 was initiated. Some of them have been reimagined over the years, and some are new programs that have come along with federal funding. You will find some variation on the theme of these services in every state. Our Maryland Access Point provides information and assistance and options counseling. We call this our gateway, our ADRC. You may hear it called that in different states outside of Maryland. But this is the starting point of finding out what's available in the state. And it's critical for people who are just turning 60, people who are caregivers and trying to understand what's available. And when we think about isolation, The counselors and the operators of the access point have a keen ear for recognizing the types of services, whether they are nutrition, health promotion, disease prevention, elder abuse, family caregiver support, long-term care ombudsman programs, senior legal assistance, and even unbiased counseling for Medicare beneficiaries to help them make choices in their health insurance and to reduce their out-of-pocket costs for Medicare. Next slide, Lisa. Our state-funded programs really focus on diversion. Under each and every one of these programs, two of which focus on housing, one on guardianship, and one on gap filling for care services and coordinated community-based in-home services, they're all focused on diversion, making sure that a person can remain independent and in their homes or living space for as long as they would like in the community. Our state really takes diversion very seriously. Our goal is to continue to work hard to define what difference we're making through these programs to ensure that people don't advance unwanted into types of housing that do not necessarily meet their needs. Our nutrition services program has been around, is probably one of the oldest programs of our department. It's taken on a very new life since COVID-19. The pandemic has increased the volume of meals going out into the community by over 400%. Now, this is due to the fact that our adult daycare programs, our senior centers, and our congregate nutrition sites all over the state remain closed. Since the beginning of the pandemic, 5.4 million meals have been served. All of these meals were either home delivered or available for grab and go. Our department is working very hard to increase the economic stimulus in the state through a restaurant initiative. And this restaurant initiative has our local area agencies on aging engaging and contracting with meal services that are not your typical older adult meal services. They are working directly with restaurants. They're helping those small businesses to stay afloat. And those chefs are preparing restaurant meals that are delivered to the door of our participants. There are about 18,683 clients that have been served during the pandemic as of January 2021. And each of these clients may actually receive more than one meal a day. There may be multiple meals and meals packaged for the freezer. Next slide. Virtual senior centers. Well, who could have imagined COVID-19? We certainly didn't. But our area agencies on aging got to work. And we now have 16 of our 19 jurisdictions with virtual senior centers. And these virtual senior centers are really available for use anywhere in the state. If you live in Western Maryland, it doesn't prevent you from contacting or logging on to a virtual senior center in Frederick, Maryland, or St. Mary's County. The virtual senior centers are open and free of charge for anyone seeking to explore. This is a way that we've creatively been able to continue our evidence-based chronic disease self-management classes, some of which address chronic diseases such as diabetes, but more importantly, falls prevention and even depression. And I say more importantly because during this time of COVID, some of the chronic disease self-management classes are straight to the heart of what it means to be isolated and provide much needed supports and recommendations. Through Facebook Live, YouTube, Zoom, and other platforms, our area agencies have been quite creative in bringing what they would normally get in a congregate setting right to the desktop and even to the telephone for those who don't have actual computers at their disposal, but may be able to join some classes and listen in and be a part of conversations. Tai Chi, meditation, and yoga are offered, online live workouts, and even virtual museum tours around the world. Next slide. Now, we don't typically think of the Maryland State Ombudsman Program as an isolation or a COVID-related service. Our ombudsmen are truly a part of the department's advocacy mission. These are trained volunteers who go into nursing homes, not only to check on the well-being of residents, but also to look around the space and ensure that there is safety, that there are no obvious violations that can be spotted. And even for some, they've become so adept at their work, they're able to spot things that the average eye would not be able to glean. So protecting the rights and promoting the well-being of residents of long-term care facilities is the primary goal of this program. The services are free and confidential. And during COVID, the ombudsmen are working remotely. But again, as you can see here, here's a wonderful picture of how even during COVID, an ombudsman might bring that heartfelt support of a resident. Think of this woman in pink, perhaps not having anyone in town to visit, but the ombudsman is there to provide a sense of connection and perhaps limit or reduce a sense of loneliness. I'll stop there and give you an opportunity. We may have a moment for questions. We invite you to put them in your chat. But if our agenda is tight, please know, as was mentioned at the top of this presentation, that we will respond to any and all questions that you may have. So I certainly look forward to your questions, and we will get responses to you. Now, I mentioned with every slide, check out our website. So please, our website, aging.maryland.gov, has a really in-depth story of everything that I've covered here today and much more. We invite you to take a cruise around our website, learn more about us, get engaged, volunteer, share our website, pick up on our social media platforms, follow us, like us, and help those who are isolated become more aware of the services I've shared with you today. I thank you.
Great. Well, thank you, Deputy Secretary Hutchinson. That was a really informative presentation. I'm looking at the chat box, and we do have a few questions that come in addition to some thank yous for the presentation. So first we have Zane, who asks whether patients have to go to the warehouse in order to pick up their equipment to go back about midway.
So we've not opened yet, but we are working out all of those details. Keep following us, and we will have those details all worked out shortly. This service is not yet available to the public, but it will be soon. And I'm sure we can expect that once that match with the equipment is made, that we'll be able to spell out very, very specifically what options will be available for pickup, for delivery, and how we'll connect that actual equipment to the individual, particularly when it gets to hospital beds and motorized wheelchairs. These things are very, very cumbersome So we will have that spelled out.
Okay, great, thank you.
Mhm.
I jumped on, a question just came in from Lee Newcomb, and she would like to know whether there's going to be a location on the Eastern Shore. She said she knows that was in the works, but is wondering if there will be.
Okay, and I'm going to see if she has a moment to chat back. A location for which program? Is this the durable medical equipment, or is it one of the other programs?
Yeah, the loaner program, she says.
The loaner program. So this is just the beginning. And if you heard a buzz about trying to get one of these across the bridge, then you know, our secretary, Rona Kramer, is all about making sure that there is access and that we become statewide with all of our programs. So again, we're in the early stages of launching number one. Stay tuned, keep engaged with us. And you know, if we're going to place a warehouse across the bridge, we're not going to keep that a secret.
All right, and one more question, actually two questions from Kelly. The first is, you mentioned a couple of times that it will be opening. I guess with COVID-19, you don't necessarily have an opening date yet, but she's wondering if there is a projected opening date and whether or not there's an email list that interested people can subscribe to stay informed on this program.
Contact our office at 410-767-1100. Again, that's 410-767-1100. And you'll be placed in contact with our durable medical equipment program manager, who will be able to provide all of the details for staying informed and keeping up to date with us. Mm-hmm.
Okay, we have another question from Lee on the shore, and she is wondering if there's any way the program that is set up to assist seniors with the chore-like services will continue past COVID.
I'm sorry, could you repeat that? I didn't hear that one.
So is there any way the program that is set up to assist seniors with chore-like services can continue post-COVID?
So we're evaluating any service that we have started during COVID. So there are two programs. The Caregiver Services Corps really was designed for COVID. And that program's viability will help us to determine whether or not that is something that we can continue. We're still so how shall we say, focused on the where we are in COVID, that we are trying now to evaluate the viability, what it would take to fund something like this, and whether or not we really can establish the argument and the funding source for something like this beyond COVID. Now, the Communities for Life doesn't provide chore services, but again, it certainly is that navigational tool, that person, that navigator that points to those services. We see Communities for Life as going on beyond COVID. It was actually started before COVID. We just know that it has a real relevance for COVID and isolation. So definitely Communities for Life. The Caregiver Services Corps, you know, will continue to evaluate that and figure out what it means in terms of sustainability with funding.
Thank you. And another question from Sabria. She says, thank you very much, Deputy Secretary Hutchinson, for the information. And she's wondering whether there will be access to vaccination. Someone just added something. Hold on, sorry. Will there be access to vaccinations for individuals in the senior programs?
So if you've been following the media, you may have loosely heard about tiers and prioritization of the vaccination process. Our governor, Larry Hogan has addressed the state and has provided our state's particular protocol and tiers for when vaccinations will be issued. All of our area agencies on aging are working with local health departments. And those local health departments, of course, are, if you think about it, goes from the governor to the state Department of Health and then to the local departments of health. So we, at the state level, are engaged with our state Department of Health, but our area agencies on aging are working very closely with their local health departments to establish the actual locations and the timing and the publicity and the announcements. So keep watching and keep informed. And there are some tiers that I'd like to share, Diane, and if that can go out to the participants. But please feel free to log on to the governor's website. Those tiers are spelled out there, as well as we will probably have them up on our website shortly. Everyone's working really hard, and the goal is to ensure that we use those tried and true locations like senior centers and other places where we know people are familiar, and much like we use a grab and go philosophy with the meals, where you have a line of people coming to the senior center and there's a person that actually hands the meal package. It's not unlikely. We've seen flu shots done that way, and we can certainly envision that the idea here is to make things as easy as possible. We are so much committed to making sure that older adults, people attending the senior centers, people who are isolated and in their homes, not only know what to do, but also know where to go. Mm-hmm.
All right. Okay. So for the attendees, there's some information that Suzanne Forno from the Maryland Department of Aging is placing in the chat box. It's the link to the vaccine tiers. And we'll also, Joy with AHEC West will also send that to everyone who's registered for the conference. The telephone number for the Maryland Department of Aging is posted, and Suzanne also posted some information about the DME sites on the Eastern Shore for those of you who are on the shore and interested in that medical durable equipment launch. All right. Okay. If there are any other questions, attendees, you can continue to put them into the box, and Joy will compile them and send them to Deputy Secretary Hutchinson and get responses back out to everyone.
I'd like to thank Lisa O'Connor and Suzanne Forno for joining me this morning and making sure that we could provide you with everything that we have to offer. So Suzanne, thank you for chatting. And Lisa, thank you for advancing those slides and keeping me on track and on time. And we certainly appreciate being here with you all. You do tremendous work, and we are just proud to support what you do.
Well, thank you again. It was really great information. It's wonderful to see how much Maryland and how hard Maryland is working to meet the needs of older adults, not just during the pandemic, but also launching these new innovative programs. I encourage all attendees at this conference or this webinar to do visit the Maryland Department of Aging's website. You can find all of the information about these programs and more, along with information about volunteering for some of the programs that Ms. Hutchinson had mentioned. And also remember that each county has its own Bureau of Aging, so you can become involved in your local communities as well. Our next presenter is Dr. Wilbur Chen, and Dr. Chen is Chief of Adult Clinical Studies Center for Vaccine Development at the University of Maryland School of Medicine. He's an adult infectious disease scientist with a specific interest in clinical vaccinology, and he's also a member of Governor Hogan's COVID-19 task force. Welcome, Dr. Chen.
Good morning, and thank you so much for having me. Can you hear me? Hopefully, and let me go ahead and see if I can share my slides. So hopefully I'm successfully showing my slides right now. You should see a yellow banner. So let me say that I've been given about an hour's time, and what I'd like to do with this hour is to try to give in broad swaths a clearer understanding, hopefully, of this COVID-19 pandemic, to give you kind of some context behind it. I have to paint in broad strokes, so I can't get into many of the details, but I am a vaccinologist, so I think, again, I can try to address some of the concerns with the vaccines that are now being deployed, which is really exciting. And I think I certainly want to, first of all, just recognize that there's a lot of fear, distrust, questions, and concerns regarding these vaccines, but also therapeutics and even the virus itself as it rapidly emerged, just short of 12 months ago. So, and then it's funny because Deputy Secretary Hutchinson said, take a cruise of the website, and I thought that was funny because taking a cruise these days is not something that we're able to engage in. But I think, my hope is that as we deploy these vaccines and get out of this, we can get back to normal life, which would be something like taking a cruise. So Deputy Secretary Hutchinson, thank you for that really clear presentation of all of those resources, which is just fabulous. And I just wanted to say, again, there's a lot of misinformation, conflicting information out there. There's been a movement of anti-vaccination for many years, even before all of this, which promoted a lot of false information. So this is what we're working against. There's also a long-standing history of distrust, especially among communities of color. And so I certainly readily recognize that. And that's a growing wave that we need to work against as we continue to voice kind of the value of these vaccines that I'll be talking about. And certainly we want to be sensitive to our population that we discussed. So anyways, that's just my introduction. Let's go ahead and go through my presentation this morning, which will be, again, taking us over a lot of different topics. So again, I'm going to talk about transmission of the virus, some therapies, but then I'll spend most of my time talking about vaccines. So I do have some disclosures that are related to COVID-19. I am working with the Maryland Department of Health on some serosurveillance, and I'm funded by the CDC to do some surveillance, and I'm a co-investigator on one of the therapeutic trials right now. So I am invested in trying to respond to this situation. And I'm going to try to outline my talk today by giving an overview briefly, talking about some very basic principles about this virus, just to make sure that I set the record straight from the scientific point of view. And that will include talking about the transmission of this virus. I'll talk about therapies, and then I'll talk about vaccines. So let's just talk about the overview of emerging infections. It's not a new thing. In fact, once we get over this pandemic, I continue as a scientist to try to be prepared for the next pandemic. And you can see that even over the past 25 years, we've seen a lot of pandemic potential viruses or other pathogens that have emerged. So you're seeing that list on the right-hand side. And so SARS and MERS are other coronaviruses that emerged. And now we're with dealing with COVID-19. But, even more recently, you probably recognize Ebola, Zika, dengue. So these things are, again, pathogens that we have to deal with over time. So again, I don't want people to think that once we're out of this situation that we're always in the clear. Scientists are always working in the background trying to stay ahead of the game for these new pathogens that might emerge. Whoops. So, as part of this, as scientists, we try to understand these threats. And so for influenza, which comes out every year, we try to stay ahead of the game and make sure that we don't have a new pandemic influenza. So part of that is trying to understand, that these viruses actually are naturally occurring among migratory birds. And migratory birds, importantly, fly along large flyways that cover large parts of the globe. And again, when they land into the backyard of some farmer that has domesticated animals, they interact, and can spread those viruses, and they can be spread to the pig or the chicken or the turkey in the backyard the farmer, and then eventually to the human. So again, it's always a threat out there that we're trying to stay ahead of the game. So coronaviruses, again, are endemic in bats. So, flu viruses are endemic in migratory birds. So again, as we encroach into nature and we have our spaces that go into forests and jungles where, again, bats, have their natural space, then, again, our domesticated animals may become intermediate hosts, or we may interact with the bat directly and become infected. And that could be the next kind of coronavirus pandemic. So I just want to describe to you again that this is a threat that we always are trying to deal with as scientists. So there are some basics that I just want to make sure that we really solidify, which is that we think right now that this virus has a period of infectiousness. It could be as early as 2 days from the exposure, and last for at least this time of 15 days after being test positive. And now we recognize that an important part of the infection is that you can be asymptomatic or pre-symptomatic. Up to 40% of people can have this. So they don't even know that they're infected, but they can still transmit very effectively. And so what does that mean? That means that, again, people out there, when you interact in public, may feel normal, but may be infectious. So again, as we interact with our older adults, we don't know if we ourselves are infected unless we're able to get tested frequently. And of course, we need to recognize that the burden of disease is highest among older adults. So you're seeing this graphic here from the CDC, which is showing you, really hospitalizations and the risk of it that rises significantly with age. So let's talk about transmission of this virus. So, it's so efficient, and it's through something called exhaled breath. In med school, we're usually taught it's respiratory droplets, which is a big size, and it drops out of the air within 5 feet. Well, it's actually much more complicated than that. And we can also contaminate the environment around us. This is called fomites. And so, of course, if we cough or sneeze on our hand and then we touch a doorknob and someone else comes back and touches that doorknob and then wipes their eye, then they get infected. So that's how that can happen. Now, the concept of exhaled breath is that it's not just a respiratory droplet, that we know that, again, the respiratory droplet we teach is 5 microns or higher, which means that it drops out of the air. But we know that these infectious particles can be much smaller. So that means that they stay suspended in the air much longer. They can be carried very efficiently in air currents. That's why we say indoors is much worse than outdoors. Outdoors, is dining and other things is much better. And of course, ventilation with the outdoor air, rather than having recirculated air like we have in the winter time because it's cold, is a poorer environment. I'm showing you a colleague of mine at College Park who is a scientist who studies airborne pathogens, and so he's been my close colleague. And so he invented this Gesundheit 2 machine, and so it collects exhaled breath and has been analyzing it. We've been working together many years, and so this is mostly influenza research, but now we're of course responding to COVID. But again, we're trying to understand scientifically these infectious droplets, which again, we should be using the word exhaled breath rather than respiratory droplets. So just to give you some examples to just illustrate how infectious these particles are, here's an illustration of a call center. This is in South Korea, where again, there was this really dramatic outbreak. This call center, of course, requires that people are closely seated to one another. This is, a bank of people that are that have their headsets and are responding to, help desk sorts of questions and those sorts of things. But you can see that 94 confirmed cases out of 216 employees on this one floor were infected, and how close proximation they were to one another. There were also other people who also were infected on the other side of this partitioning area, probably because they had shared space like a kitchenette or other luncheon areas that again gave opportunities for this infection. So 84 of the 94 that were confirmed cases were symptomatic. There were a number of people who were pre-symptomatic and asymptomatic during this outbreak investigation. And then there were household contacts of these symptomatic cases that also became secondarily infected as part of this outbreak investigation. But this is just meant to illustrate how easily in the indoor environment this virus can be spread. You know, this restaurant outbreak is also an interesting way to illustrate how infectious the virus is. So there was a patient, patient A1, you know, who went to a luncheon with his family at table A, and eventually members of this table were infected as well. As part of the investigation, there was a family B that overlapped with the luncheon with table A by only 53 minutes. And then there was table C here that overlapped with their luncheon with table table A for 73 minutes. And you know, you can see that eventually there were people that were again found to have confirmed infection as part of this outbreak. Now, what's interesting is that they did have an air blower that was blowing air in this direction. So how is it that people in C actually got infected? Because you wouldn't think the air currents would actually be carried over effectively so that these people, well, when they did indoor environment kind of investigation and looked at it, they actually were able to map out how, again, because this is at the end of a room, that as the air hits this wall, it recirculates back and you get a vortex effect. So what happens is that, you know, again, the people who are here who are infectious, this one person infected not only his own table, but the people in the next table over. But the vortex effect also brought infectious particles back to this table here. Now, no one else in the other parts of this restaurant were infected. So this is really an important way of helping us to map out how infectious these particles are carried along by those air currents. Now, I think it's very, most of you probably know about this choir outbreak. So this choir only lasted for about 2.5 hours. 61 people attended this choir, and 53 of them, 86.7% of the choir practice attendees became infected during this time that they were practicing for 2.5 hours. So again, that illustrates, and this is a nursing home. So maybe, again, trying to bring it a little bit closer to home for this notion of older adults. So in this nursing home, there were 7 different wards. This one particular ward had a recent energy efficient system that was installed in just that one ward at that time. And what that meant was that this system basically had a sensor so that only when the carbon dioxide level kind of rose to a certain level, the air system would kick in and refresh the air and recirculate the air. Now, the other systems were called inefficient. So that meant that they basically were on all the time. So again, you know, when you're talking about energy efficient systems, you have to, you know, kind of balance out, you know, that it's not on all the time. Basically, it only turns on when the temperature goes lower and you have to rewarm or whatever else. That way, you're not always wasting energy. Well, on the other hand, you're not recirculating air, you're not circulating the air effectively. So in this one ward, 17 residents were infected and 17 healthcare staff members. None of the other wards were affected. So that gives you an idea of how indoor ventilation is really key to defeating this virus. Now that doesn't, that means that we have to run our HVAC systems in an inefficient way, which again, during a non-pandemic year is a good idea. But during this pandemic time, we have to kind of think really carefully about indoor ventilation. So, you know, this really speaks to, you know, what we've been preaching for the past 12 months now, you know, these mitigation and control measures. We're trying to make sure that when we're in close contact with people that we maintain PPE. If possible, in our work environments and other environments, we have administrative changes, which means shift work or other things to really decrease the density at the workspace. We try to maintain physical distancing, so we have barriers in place and those sorts of things. And of course, the best practice is if you have the option to do telework, which means telehealth, oftentimes when we're doing our occupation, teleeducation for our children, the K through 12 and colleges and universities. And again, we need to continue to, you know, work as a system to optimize contact tracing, making testing available and those sorts of things. And we of course have a personal responsibility to maintain universal masking, staying home when ill, and really trying to minimize our circulation in the public as well. So all of these things are things that we should continue to preach as really important tenets as we combat this pandemic. Let me talk just briefly about therapeutics. There are a lot of different things that have been tested over the past few months, and we're trying to hit all these different parts of the virus. So the virus, has to enter into the human host, it has to replicate, has to do it, and then it buds out. So all of these different therapies are meant to kind of combat the different areas of that virus. And we want to think about, each of these therapeutics that we're testing, how much efficacy is involved with it, and also how much harm. So sometimes the harm will outweigh the good. So again, some people say, oh, hydroxychloroquine, well, how much harm could it do? But if it gives me a little bit of efficacy, then it's worth it. Well, we actually found out that it actually is pretty harmful. It resulted in a lot of adverse effects, and we found out the efficacy is really nil. So yes, the harm did outweigh the efficacy, potential efficacy. So we have to just kind of continue to look at that. There are right now, as of just 2 days ago, 649 different therapeutics that are in various stages of development, and a lot of them are in the early stages. But again, it's just to give you an idea that we are, as a global kind of community of scientists, trying our best to try to see if we can come up with therapeutic solutions out there, and that we have found a few. So remdesivir seems to work, dexamethasone as well, a steroid. A cheap steroid that's been around for decades. Baricitinib, seems to have perhaps some utility. We need to continue to study it. There are 2 monoclonals now that are EUA approved. So, again, the evidence continues to increase, and I don't claim to be really the one that is in the know for all of these therapies. So I think, again, I'm giving you references here for you to be able to go really to the source. But I would encourage you that are engaged in the care of patients and that are thinking about some of these therapies to really stay abreast with the data that's out there, because I don't claim to be really abreast of all of the data. But I do know that there are resources that are out there that are trying to help practitioners to try to understand what are the best ways to manage COVID-19. So, again, we have to think about the disease severity. So, I myself get calls very frequently about older adults and what to do. So some of them are, have found that they were test positive, and this was after a family gathering or some situation, and they're not hospitalized. So some of these people, again, may be eligible to receive the monoclonal antibodies. Dexamethasone should not be used in this situation, but when they're hospitalized and don't require oxygen, then it requires a different algorithm for treatment. And again, so again, there's different ways to think about the therapeutic modalities that we can use to treat our patients that are at high risk. And again, for older adults, it's they are high risk patients. So that's kind of really what I wanted to briefly say about therapies. Let's talk about vaccines. So there's a lot of course, questions about it. I'll just talk first about all of these broad-based platforms. So all of them are really trying to, in different ways, express the spike protein. This is the coronavirus, and so there's this protein that studs the outer part of it. That's what the immune system sees first, and so this spike protein right here is what is being expressed. We have a lot of what we call platform technologies that are being used. The traditional approach, this is like when you think about flu vaccine every year, still uses the chicken's egg to make the vaccine so that we can replicate the virus, inactivate it, process it, purify it, and put it in a vial, and that's what you inject in as the vaccine, a purified subunit vaccine that's made from viruses that are grown up in chicken eggs, a very old technology. Now we have newer approaches, of course, that we make vaccines, and so some of our flu vaccines are now made by cell culture, which gets away from that chicken egg, which is very antiquated, but we still use. We also have live attenuated vaccines. So this is like measles vaccine, yellow fever vaccine, flu mist, a flu vaccine, the nasal vaccine is made by live attenuated. There are recombinant approaches, which is where you take in a bacteria and make it express the protein of interest. This is a recombinant protein approach. And so again, it's trying to make that spike protein. So again, our hepatitis B vaccine, made for many decades, is done by recombinant protein. We have an influenza vaccine that's made by recombinant, and there are a lot of other recombinant protein approaches. And then we have vaccines that are basically use adjuvants. So the shingles vaccine, Shingrix, uses an adjuvant, and that's why it is such a successful vaccine. We're seeing, 99% efficacy with this vaccine, quite remarkable. And it's because of these adjuvants that are very potent, that stimulate the immune system. Now we're moving into future approaches for the COVID vaccines. And this is where, again, that's why people have a lot of questions about why are these, how can they be made so quickly? Well, it's because we're using these better and future approaches for making vaccines. So this is the DNA or the mRNA approach. And the mRNA approach is what has been successful with the Pfizer and Moderna approach. Virus vectored vaccines. So this is the AstraZeneca and the Janssen vaccine. And the Novavax is a nanoparticle-based vaccine that also incorporates an adjuvant. So again, these approaches, these future approaches, I call them. Now in a year, I'm going to have to not say future because it's right now present, but it is the latest approach. And so this is the way that we can make vaccines both faster, but also more facile in being able to deploy them to the population as well. So as soon as we're able to sequence these viruses or these new pathogens, we can basically use these newer approaches to be able to make these vaccines. So here are the leading vaccines. Pfizer and Moderna, I already said, are the mRNA-based approaches. The AstraZeneca, which is working with Oxford, that's a virus vector. Johnson & Johnson, or Janssen, is their subsidiary. They also have a virus vectored. Novavax is that nanoparticle. There's a company called Inovio that's making a DNA. That's really, we're not hearing much about it, but I know as a scientist. Sanofi Pasteur is working on a recombinant, was working on, and I'll show you a slide, just to say why I'm saying was, which is combined with an adjuvant. And then internationally, the Russians have their Sputnik 5, which is an adenovirus vectored, virus vectored. China has two different vaccines. They're both inactivated virus vaccines, but they're made by that cell culture that I talked about. India has actually 3 different vaccines that are under development. Some of them are approved. India, actually, their Covishield is actually the same as the Oxford, so it's actually really the same as this one. Bharat has a cell culture-based one that also is adjuvanted, and this company in India called Cadila is a DNA-based vaccine. So again, it's really only just to describe that there are all these different platform technologies that are being used to make these vaccines in an extremely short amount of time. Now, there's a licensure pathway that is being followed. And again, there's a lot of questions and concerns. Are we skipping over procedures? And the answer is no. The licensure pathway for a therapeutic, a vaccine, or whatever else in normal times uses the same process as well. We have to test it under a phase 1, a series of phase 2, and a series of phase 3s normally. So again, we're going through this process again, a stepwise process for the COVID vaccines. The phase 1 concentrates on safety, and it usually involves 100 people or so. The phase 2 then expands out to hundreds or thousands of people, and that's where we continue to look at safety. But then we start looking at the immune response. And the immune response is, again, taking blood and measuring antibody and other things to help us to understand whether or not the immune response will help us to predict whether or not it's going to be protective. But then it's not until when we get to the phase 3 that we actually can see definitively whether it has that efficacy, whether it can protect. And that's when we have tens of thousands of people being tested. And the FDA actually published guidance very early on to make sure that it was clear to the public, but also to industry as well. What are the guideposts that are necessary for licensing these vaccines? So again, it's a transparent process that was made very clear from the very beginning on what are the milestones for success for a vaccine and what is going to dictate failure. So, one of the things that was important was that, it had to be tested, these vaccines, in order to be licensed in the population and in a population that is generalizable. So that means that it can't be just healthy young adults, because of course we want to protect older adults. We want to protect adults that have underlying high-risk conditions like hypertension, diabetes, heart attacks and strokes, and those sorts of things. So we need to make sure the FDA wants to see that these vaccines are tested under populations that are very generalizable to the rest of the population of the US, so that we can assure that these vaccines are going to be efficacious under those instances. The efficacy has to really demonstrate preventing symptomatic lab-confirmed infection. And if possible, it should also try to prevent against more severe forms of the infection, so hospitalization and death, respiratory failure, and other things. And the statistics, which means that, again, these studies have to be big enough to demonstrate and at minimum 50% efficacy. So that's the minimum to be useful. And of course, we are very happy to see that the vaccines that have been licensed so far, the two, have been extremely successful and really hit it out of the park in my own mind. And I'll show you a slide on that in a little bit. So, what can we not evaluate before approval? What can we say and what can we not say, in other words? Because again, we are only able to test it in tens of thousands of people. We're not going to continue to test it in millions of people because we need to respond to this pandemic before we can, so we have to at least say, look, we know that these vaccines are useful, they're efficacious, they're safe enough that let's start deploying them. So for the safety part, when we approve them, we can say, okay, well, we know enough about the common adverse effects because we've tested it and we've seen these types of effects. And so that's why we can say, you know that you're probably going to get a sore arm, you might have some muscle aches and pains, but they really self-resolve within a day or two, maximum of 3 days, and then they go away. So they're not long lasting. We can say maybe something more about the less common side effects, but really only the ones that are on the order of 1 per 10,000. But if they're rarer, we can't really detect them because we haven't tested them in, if it's going to be occurring in 1 in a million, we have not tested it in a million people yet. So we continue to evaluate the safety information even as we deploy it, and we try to communicate that to the public. We also don't know if there is, in theory, some long-term adverse effect, because of course we only knew about this coronavirus for about 12 months now. So how are we supposed to know about long-term side effects of this vaccine with scientific definitive statements? Now, there's no scientific rationale for having long-term adverse effects with these vaccines so far. But again, when we communicate to the public, we as scientists try to use evidence-based fact data to be able to back up our statements. So again, when we say safety, we're really saying that we know enough about the common adverse effects and the less common adverse effects, but not the super rare adverse effects, which again, we're trying to detect as we continue to monitor these vaccines as we deploy them. And of course, the efficacy, we can say that these vaccines prevent symptomatic illness. We can say that these vaccines may have some effect on whether or not they prevent medical complications, hospitalizations, and deaths. But we don't really have enough data because of these studies, the way that they were designed, on whether or not they can really stop asymptomatic infections, whether or not they can basically prevent transmission. We don't know how long these vaccines will last, the duration of protection. So I don't know if you need to get revaccinated every year or every 5 years. And we don't know definitively if there are big differences in subpopulations. So again, a lot of questions are, I have HIV, AIDS patients. What's the efficacy in those? I don't know really. I think it's better than nothing. I think that again, we don't believe that there's going to be harm. Transplant patients, cancer patients. We did evaluate in those studies HIV patients and cancer patients and others, but again, we can't say with definitive knowledge on what the efficacy is. It probably is a little bit different, but I don't know how different it is. So here is a way for me to try to illustrate all of the vaccines that have been in the pipeline, at least the big ones, that you might hear about in the news. So Pfizer and Moderna are the ones that have been approved now, 95 and 94.1% efficacy. I really think that these are pretty much the same efficacy. I don't think that one is better than the other. They're both the mRNA-based vaccines. They're both 2-dose vaccines. Pfizer is separated by 3 weeks and Moderna by 4 weeks apart. AstraZeneca and Johnson & Johnson are imminent. You know, they basically began their phase 3 studies. They are going to be announcing them very soon. It sounds like that we might hear about the Johnson & Johnson in the next couple of weeks, hopefully by the end of this month. AstraZeneca might be a little bit longer. Now in the UK, they've already approved it and are using it. But here in the US, we're still waiting for the US data and the US trials. And so again, we might not hear about that until maybe end of February. But again, it is coming soon, and you know, it hasn't failed yet. Novavax, actually, the phase 3 just started. So you know, just while we were in the holidays, it was starting up. Now, I mentioned these two just because I wanted you to understand that this process that I'm describing back here, where we're going stepwise through, is a process that works. So Sanofi Pasteur GSK was being evaluated and was halted. Why? Because in their phase 1 study, they found that it had actually poor immune responses among older adults. So that predicts that you know, that it won't have very good efficacy at all against COVID for older adults. So if we predict that it's not going to be very efficacious already early on, then we halted that one. Okay, they're going back to the drawing board to see if they can reformulate and make it a little bit better so that it will be have good immune responses. Now, there was no safety concern with this, so they're going to try again. But at least this particular vaccine, the way it was halted. CSL is another company that actually makes a lot of flu vaccine. They're located in Australia, and they were teamed up with a University of Queensland, and they were using what we call molecular clamp platform technology, which I really didn't describe, but it's another unique way of making a vaccine very quickly. They were halted, and that's because in the phase 1 study early on, they showed that some of the patients that were vaccinated, they had an antibody response that made a false positive HIV test. Now, let me be clear, it did not give them HIV. All it was that when you took their blood and they could show that that blood would cause a false positive HIV test. Okay, so and it's because of cross-reactive antibodies. So again, that could be a safety concern if you ever thought about deploying such a vaccine. So again, they halted that one. That one's not going to go forward at all. So again, that's just to describe to you that we have procedures in place to say whether a vaccine is successful or not successful. And these are two examples of unsuccessful vaccines that did not go forward. So I want to show that, again, this process is working. Here, I'm just showing you just some evidence of the vaccine efficacy. And so here you can see the Pfizer vaccine for, these are the placebos where, again, the events continue to accrue where people were getting real infections, and then people who got vaccinated actually were protected. And again, this is, the colors are different, but anyways, these are the placebos and these are the people who were vaccinated. Again, you can see very clear demarcation of the efficacy that is shown even after that first dose. So the primary efficacy endpoint in the studies, the 2 doses, shows 95, 94.1% efficacy respectively. But if you look closely at the data here, even after 1 dose, there is some evidence of some efficacy. Now, we don't know how long that lasts, and we didn't formally test that. So I don't really want people to be talking about, oh, the efficacy of 1 dose, because we really haven't studied it very carefully. But there is good evidence that 1 dose does give some protection, but it might be short lasting. So we, again, don't want to just preach that we give the 1 dose. We want to promote the 2-dose regimen. And there is efficacy against more severe disease. So again, when we looked at the data in these studies, you know, for hospitalization, for whether or not they required oxygen, those sorts of things, you know, 90 to 100% efficacy, that's really terrific. Wide confidence intervals, but again, that is evidence that these vaccines are very, very valuable in terms of the benefit to the person that receives them. Now, as part of vaccines being deployed, we need to understand that there is a lot of policy making around it and how they're implemented. So we understand right now that there is a very limited vaccine supply, and we have to think carefully about allocation of them. And part of that is prioritizing these vaccines to the highest risk parts of the population. And so the thinking is, healthcare workers, frontline essential workers, those sorts of things, to make sure that we maximize the utility, maximize the benefit of these vaccines when we have a short supply. And a lot of this the allocation has been thought of under an equitability and ethics framework, which means that we really think carefully about how we can make these vaccines equitable, how we can be justified ethically about the way that we allocate them as well. And this is what formulates the national guidelines, the policy for those national guidelines. But we also allow for a lot of flexibility because the local jurisdictions, the states, the counties have to also have flexibility because each population is different. Rural America, so Western Maryland, is so different from the central corridor of Maryland. And so the Midwest of America is different from the coastal regions. So again, we need to have jurisdictional flexibility to be able to implement these vaccines. And that means that we have to recognize the logistics. So it's very, going back to that prior slide here, the logistics is that, again, these are 2-dose regimens separated by different intervals of time. There's also different storage conditions, the ultra cold storage versus others. So again, a lot of that plays into the logistics planning. And so that also plays into the ability for us to deliver these vaccines. Now, what I'm trying to do today is to help you to formulate your public health messaging as you talk to your patients and the people around you, and to talk about the value of vaccines. And all of this is meant to, again, maximize the benefits, minimize the harms, speak about equity, justice, fairness, transparency, make sure that we're always making these decisions and communicating in an evidence-based manner, and making sure that as we implement these vaccines that we're doing it feasibly. This is to illustrate again, when we have limited vaccine supplies, our strategy right now is to try to target immunization to prioritized populations. But as we start having, more and more stocks of these vaccines made available, we'll move into the ability to surge, which we're currently, trying to build up, and using the more innovative broad-based delivery approaches. So that means that that's why you're going to see Walgreens, CVS, Rite Aid. You're going to see smaller, individual pharmacies. You're going to see, of course, medical offices, but maybe even dentists, maybe even allied care workers, again, being deployed to be able to deliver these vaccines. Again, in rural America, you may be many miles away from your closest neighbor. So how do you make these vaccines easily accessible to those types of populations versus even an urban population where there's high density, but there are areas where you are, isolated because, there are lack of resources for you, even though you are in the center of the city, to be able to get to the local pharmacy or whatever else, again, so we have to make these vaccines easily accessible to the local population. And even in the final phases, while there still continues to be lots of vaccine, there will be vaccine hesitancy. So we need to continue to stress the importance of vaccines and make vaccines available and talk about the importance and the value of vaccines so that we can immunize people who have not yet been vaccinated. So let's overcome the vaccine hesitancy that's out there. And so again, this is that pyramid, that approach where, again, the highest priority people are healthcare workers, residents, and staff of nursing homes. So Deputy Secretary Hutchinson touched on this again, nursing home populations and others that are at high risk. We're trying to deploy as part of that phase 1A. First responders, public safety and corrections, Then we'll move into assisted living in congregate settings in adults 75 years of age and older. Again, and so on into the general population. But again, as we move through the phases, again, our idea is we're trying to allocate limited resources, but as they open up, we're trying to deliver them. But they are difficult to deliver in a short period of time. There are a lot of population risk groups. So, all throughout the US, we have 330 million. Healthcare personnel is 20 million, long-term care facility residents, 3 million, essential workers that are non-healthcare, 87 million, but you can split them out because not all essential workers are necessarily frontline. So there are some that are actually able to telework successfully. So that's why we separated out frontline essential workers versus others. Older adults, of course, are another significant part of the population. And even when you separate out by decade, the 75 plus is 21 million out of the 52, and then the 65 to 74, a lot of them still engaged in their own occupations. And so again, hopefully trying to successfully telework, but again, that's a significant portion of the population, 31 million. And adults that are 18 to 64 that have the high risk medical conditions, that's a very significant part of our population, nearly a third of our population. So again, when we think about our population, they're not discrete and separated. A lot of them overlap. So you might be a healthcare personnel who is older than 65 and has diabetes. So you're in this space right here. So again, we have to think about risk in these terms when we allocate these vaccines. So, I tried to, in broad terms, talk about this present pandemic. And there are a lot of therapeutics that are being evaluated right now. There are monoclonal antibody therapies that are EUA approved that we're trying to use. Glucocorticoids and remdesivir are being used predominantly for the severely ill. We don't want to use chloroquine. That's proven not to be useful. There are a lot of other potential therapies that continue to be studied in randomized controlled trials. So just be aware of that and try to stay abreast of that information. There are a lot of vaccines that are being developed as well. Moderna and Pfizer are the ones that we're deploying right now. The Johnson & Johnson and AstraZeneca, I believe, are imminent. So just stay tuned for that. We'll hear about them soon. At least they seem to be successful so far. So, that's why I am hopeful that they will be numbers 3 and 4 respectively to be deployed here in the US. And then there are other vaccines that are out there globally being used. Again, when we think about the globe, the world, we have US vaccines, but there are those other vaccines that are also being developed that won't be considered for the US, but are being helpful for combating this pandemic worldwide. Because if we defeat COVID-19 only in the US, we will continue to have outbreaks in other parts of the world where there's efficient transmission that can always be reintroduced back to the US. So we won't be out of this as a world until we eradicate it all throughout the world. And so that means we have to have a plan for vaccinating the entire world. So those other vaccines that are being globally developed are very, very important for us to be able to get past this pandemic. So, this is just to give you an overview, again, of that way of how we develop vaccines and therapeutics. We have a very efficient way, a broad platform technology way of discovering and bringing these vaccines very quickly through so that we can go through phase 1, 2, and 3 testing in a short amount of time. And we have a process for the regulatory approval and all of this to be done. Financing is being done with Operation Warp Speed here in the US, so this is taken out of the equation. A lot of these other things are being truncated and done not sequentially, but in parallel. So that's how we're able to do this entire process here, which is the normal time frame of 10 years, we were able to do within less than 12 months. We're now trying to deliver them. We're now trying to make an impact with these 2 vaccines. So there is a public health need. Normally, there's a market need that we have to make for a vaccine to be developed. We're taking that out of the equation because we don't care about the market. We just want to worry about the public health need. And of course, right now, there's a lot of political will throughout the world that is pushing for us to develop these vaccines, but also continue to study newer therapeutics to be able to manage the pandemic as well for hospitalized patients. So my last slide is to thank you all very much to try to get vaccinated. Here I'm showing myself getting vaccinated. This was just last week. And I'm saying that I'm getting vaccinated because I want to protect my family. I want to save my patients. I want to increase community immunity around me. And I want to open up Maryland. So my last reminder is to make sure that you keep all vaccinations up to date, including your annual influenza vaccination. Maintain a healthy diet, a mental attitude, and physical exercise. Even though we're all constrained indoors, try to maintain your exercise. And I encourage all of you to become a vaccine ambassador. So thank you very much.
Right. Well, thank you very much, Dr. Chen. That was really important information. I actually heard on the news this morning that 30 to 40% of people who have been offered the vaccine have actually declined it. And so there is a lot of fear around it. And so I hope that the attendees this morning have some of their own fears put to rest and, like you said, become vaccine ambassadors. So very good. Thank you. We do have a number of questions that are coming in. So we'll start with Amy. Amy Rizcala writes, is there a vaccine modality that has shown the most efficacy against COVID-19? For example, RNA attenuated, recombinant, and also, so it's a multi-question. Also, given that we do not know the long-term effects of the mRNA vaccines, do you recommend that healthcare providers still get vaccinated, or should they wait until other vaccine modalities become available?
Yeah. So, I think the first question about the different vaccine platforms and their efficacies. Well, so far we only have the evidence that's been published, publicly about the mRNA-based vaccines, and they have that nearly 95% efficacy, which is so terrific. I mean, all of us just cheered and applauded when we saw the data, and it was so clear about the value of those two vaccines. The AstraZeneca and the Johnson & Johnson, we've seen spits and spurts of that data. I haven't seen the actual raw data itself, which is what we typically like to see before we make more definitive statements. But, what I've seen so far for the AstraZeneca is that it has a little bit conflicting data, but still positive data nonetheless. So some of the data says that it's 70%. The other evidence said 90% efficacy. So if it's anywhere between 70 and 90%, that's still terrific. I mean, that's so valuable in that it can deliver, that much protection. So again, 3 in 4 people will get protection from symptomatic disease, and that might, that's just symptomatic disease. But you can think about, if it ends up preventing hospitalizations and deaths, you can still have a huge effect in a population that gets that vaccine and really be able to combat COVID-19. So that really makes those vaccines very, very valuable. I don't like to get into the situation of comparing apples to apples and just say, oh, well, I would rather get the Pfizer Moderna vaccine because of that 95% versus whatever. I would say get the first vaccine that's made available to you. It's really not a time for us to pick and choose what's the best. We really need to be able to deploy these vaccines as best as possible to immunize the entire globe, is my kind of thinking. But anyway, so that's that answer. The part about these vaccines and healthcare workers, well, I would say absolutely. If you're a healthcare worker, you are around patients, or if you are engaged in just as a caregiver of an older adult, you provide support for your older parents, then I think, again, it is extremely valuable for everyone to get vaccinated. So I would encourage everyone to get vaccinated at their first opportunity that is made available to them. mRNA-based vaccines are safe. They do not, what I've had a lot of questions. In fact, I'll just say that, yesterday evening, I was on the town hall with Delegate Brian Crosby of St. Mary's. And so I fielded a lot of questions from his constituency. And so, questions like, do mRNA-based vaccines integrate and do they interrupt with the host DNA? No, they do not. They don't disrupt or integrate or do anything to your DNA, to your genes at all. They go into you and they actually degrade relatively quickly, but they do generate a very robust immune response such that we get really great protection. So I believe in the safety of these vaccines. Another question is, about whether or not we can use these vaccines in pregnant women or breastfeeding women. And again, the answer is a little bit complicated because as a scientist, I have to say, well, we didn't formally do those studies, but we did have a handful of people, a few dozen, that became pregnant during the course of the study. So inadvertently, they were involved in the study and they did not have any safety effects. But we haven't done the formal study showing that pregnant women have the complete absence of any problems. But again, the mRNA is not interrupting the genes of the pregnant mom or the child, the fetus, or the breastfed baby. It's not carried along in the breast milk, so there's no real scientific safety concern. So again, we are allowing pregnant women and breastfeeding women to be vaccinated because again, healthcare workers among our population, we know that there is going to be about 5 to 10% of our healthcare workers are of the are either breastfeeding or pregnant at some point. And so again, we want to make sure that again, this important part of our population is given the opportunity to be vaccinated.
Thank you. Danielle asks whether, considering the statement that the vaccine prevents symptomatic but not asymptomatic COVID-19 infection, would you advise people who obtain the vaccine to continue to refrain from higher risk activities such as dining indoors or visiting their grandparents until the majority of the population is vaccinated?
That's a great question. Yes, and I probably should have made sure that I addressed this directly in the lecture itself. But you're absolutely right. That notion is that even if you are vaccinated, there's that. Remember, 95% efficacy means that 1 in 20 will not get protection, at least in the study, which again implies that you could be infectious. And we don't know, again, if it interrupts asymptomatic infection. So again, you could be vaccinated, you could have that 95% efficacy, and you might not be, again, get an infection where you become symptomatic, but you still may carry an infection. So we don't know if we interrupt transmission. So again, it is super important that we continue to maintain the attitude of universal masking, maintaining physical distancing, and trying our best to just really not be a transmission vector out in public. Again, until we have the majority of the population all around us, that what we call population immunity, or some people call it herd immunity. I don't like to use that word because it implies that we're cows. We're not. But so I use population immunity or community immunity as the term. But until we get a high proportion, which is 75% or higher, roughly, then I think we can't really open up completely.
Zane asks, what are your thoughts on cancer patients getting the vaccine?
Yeah. So again, I think cancer patients, immunocompromised patients like HIV/AIDS patients, transplant patients can and should get vaccinated. There's not a reason for these vaccines to cause more harm. Now, the vaccine response, which means the efficacy might not be as good as a person with an intact immune system, so a healthy young adult. But again, that's not a reason to not get vaccinated. In fact, these are the people that are the most susceptible. So even if the efficacy is lower, let's just pretend that it's 70% efficacy for a cancer patient, that is still much better than zero. So I think, again, it is important to consider vaccination.
And is there any research on whether it impacts or any side effects if someone's undergoing chemo treatment at the same time?
Yeah, we don't think so. Now we probably want to space out the dose so that you're not knocked down with the vaccine side effects, which again, some people will get achy, maybe feel a little bit feverish for a couple days, but I don't suggest that we would want to have that overlapping with the peak time when a person is on their chemotherapeutic regimen. And again, they already feel crummy when they're going through their therapies, and again, multiple rounds. So again, wait until the best timing in between rounds of chemotherapy is what I would propose.
Lot in the news about the allergic reactions. And so Deanna asks, what are the odds of actually having an allergic reaction?
Yeah, so I think that allergic reaction, that severe anaphylaxis, which is like, bee sting allergy type of reaction, where there might be swelling and swelling of the lips, of the mouth, and shortness of breath, and a low blood pressure and other things. Again, that can be a lethal or a life-threatening event, and so we need to recognize those. Now, the CDC recently published data on the first 10 days of the experience after many millions of doses were deployed, and there were on the order of about 1 in 100,000 of these anaphylaxis events. So 1 anaphylaxis event per 100,000 doses that were delivered. That's higher than the typical anaphylaxis that is experienced, let's say, for example, for influenza vaccination. So that's about 1 in a million. And then other, I should just say that, even Tylenol has anaphylaxis, or aspirin has anaphylaxis to the extent of, one case in a million, or 1 case in 5 million. So anaphylaxis is seen with other therapeutics and vaccines. We do see a higher rate, but I still, and what we're seeing is that we can manage anaphylaxis. So as long as we have vaccination clinics that are built out, designed to be able to observe for and to be able to immediately manage anaphylaxis and be able to treat these people and get them to be referred quickly to an urgent care center or an ED to be able to continuously be managed and to get over the anaphylaxis event, then again, I think that we can safely vaccinate the population. Now, if a person truly does have an anaphylaxis event, then they won't get the second dose of the same vaccine, and they'll have to wait for either the AstraZeneca or the Johnson & Johnson vaccine, again, anticipating that those would become available at some point soon. So they would be vaccinated with those other vaccines, but they would not get the same vaccine that they had the anaphylaxis for. So again, I think that the benefit of these vaccines far outweighs that safety signal that we're seeing, which is still rare, but manageable.
Thank you. Next, someone says, I appreciate seeing the model for the restaurant spread. Have scientists in the US been able to do successful contact tracing research, and also not just in restaurants, but also other public spaces such as grocery and retail spaces?
Yeah, people are trying to do contact tracing as best as possible, but it's so hard because it really requires, when you do contact tracing, that we can do it electronically and smartphone based and other things to be more technologically savvy about being more efficient getting the information. But when it comes down to it, you still have to sometimes talk to a person to really understand who it is that they interacted with, how long, and whatever. That means they have to pick up their phone and answer it, or respond to an email or a message, text message. And contact tracers have that problem of having to contact many hundreds or thousands of people, so one case results in a lot of work. And so that requires time. And so a lot of people do not respond back to the contact tracers' inquiries. So we're not able to gather that data efficiently enough. And of course, now that we're in this pandemic and we're seeing peak, many thousands, hundreds of thousands of new cases a day, all throughout the US, there's just not enough ability to collect all that information to a great extent. So contact tracing is such an important part of responding, but it's not going to be getting us out of this situation alone, because right now we're in the thick of things. If we were in the summertime and we were able to have distanced ourselves and this and that and done efficient contact tracing at that time as well, while still maintaining physical distancing and whatever else, we might have actually been able to get our way out of this situation and been like what you see in the countries like in Asia, where they basically had almost 0 cases throughout their own country. We could have done that if we had efficient contact tracing plus the observation of physical distancing and all these other measures during the time when the viral transmission was the lowest.
All right, we have, looks like just a couple more questions. Yep. John would like to know whether air-to-air heat exchangers on air circulation systems help to reduce spread in public buildings?
Yeah, so I'm not sure if air-to-air heat exchange. What we think is that you need to sometimes have filtration systems put in, but inline filtration means that you have to have much more fan power pushing the air current through the fibers. And so that, of course, requires more power. So that means that you're, of course, operating your HVAC at less efficiency. And so for a large building, that is not feasible to have an inline filtration system. So what a lot of people are trying to think about is in-room filtration or even UV. Now for UV, if you have inline UV, again, the air is moving so quickly that the effect of the UV light is so transient that it's not efficient. So what you have to think about is maybe in-room UV, where you bathe the upper part of the room in UV light so that it decontaminates and it deactivates the virus. But of course, UV light shown right downward into the eyes can be harmful. So again, we have to be smart about kind of how we treat indoor air. You know, the best way is to circulate from outdoor air and have a way to evacuate air that's contaminated to the outdoors, where it can be decontaminated very quickly. But again, a lot of indoor environmental scientists are trying very hard to try to tackle this problem.
All right. Min asks whether, right now she says there's no data for vaccine efficacy in children under 18, and is wondering if you know when children will be able to be safely vaccinated.
Yeah. So those studies are actually being done right now. I think that there are a handful that are being either imminently done or in the process are ongoing right now, just more recently. So again, I think the data is being generated so that we can move to the very, very important pediatric population, because they are, children are an important vector for transmitting the virus in our population. And of course, we eventually want to fully open up K through 12 and preschools. And so having the population, the full population being vaccinated is so important for us to be able to get the educational sector back to being open and operational. So I completely agree with that. Now, on the other hand, there's no reason that these vaccines won't be effective at all in children. But again, as scientists, we really don't like to, propose that we deploy these vaccines without having evidence-based data. And so again, those studies are being done so that we actually have data to back up our assertions.
And so they are really included when we're thinking about that 75 to 80% community immunity, the children under 18 being included in that. It's not just adults over 18, but really the entire population.
Yeah, that's right. Now, I don't know how young we'll go to, so we may not go all the way down to 2 years of age, but we may at least try to make sure that we hit the preschool population, so 4 or 5 years old and up, just so that we can open up those sectors of the population back, because it's so important for those parents to be able to get back to work and not have to telework and manage their kids at home. So again, we're really thinking very hard. And so even if we're not able to, develop the evidence-based approach to vaccinate really young children, that doesn't mean that young children won't be able to go back to the preschool or nursery settings. It's just that we'll recognize that they won't be vaccinated, but at least the people around them and their caretakers will be vaccinated. So again, that goes to, again, we're trying to be careful in our approach of deploying these vaccines. We want to be evidence-based, but we also want to be fair and justified. And, so I think, again, it's trying to be thoughtful about this process.
And we do have one more question, but I also know that we're up against the clock. So if you could stay on and answer this question, and people, if
Absolutely.
attendees want to take a break, they can, but if you want to stay on and listen to this response, Krishna would like a little bit more information on how exactly the mRNA vaccine works.
Yeah.
You want to take some time and do that. Joy, can you just come on and let us know what our schedule is, and as Dr. Chen is thinking about this one? So.
Yes, we are scheduled to begin our social isolation and loneliness, current crisis, future opportunity with Dr. Thomas Cudjoe at 10:45. So if everybody could consolidate their break in with listening to this remaining questions with Dr. Chen, that would be great. So let's try to stay on schedule to begin at 10:45.
Okay, thank
Yeah.
you. So again, the question is, can you explain again exactly how the mRNA vaccine works?
Yeah, and I don't want to get too deep into medical speak, but you know, the mRNA is basically what the normal human or other biological processes use to make protein. So in the cell, basically, you have the DNA. The DNA makes the mRNA, messenger RNA, and the messenger RNA goes out to the cytoplasm and then transcribes and makes protein. So all you're doing is taking mRNA exogenously, you know, through that vaccine, giving it to the body, and immediately the body makes protein directly right out of that. And then it degrades down, you know, as a natural process, as it normally does in the body. But that protein, that spike protein that's made by that vaccine being, you know, delivered, of course, is delivered to the immune cell. It sees the spike protein just as if it thought it was actually made by a virus. And so again, that immune system is mounted. And so after the 2 doses of the, you know, mRNA-based vaccine, you have that 95% efficacy. So again, it's not integrating into the body in some abnormal way. It's actually kind of hijacking a normal biological approach and making the body see that protein of interest. So that's why I talk about it as a broad platform technology, because you can think about if we are facing a future Ebola or a Zika or a future pandemic influenza, we can make that protein of interest with an mRNA-based approach very quickly as soon as we sequence that virus, and we can pop it into a vaccine and start testing it very soon. So it's a promising way for us to be able to address a future pandemic. So I think, again, this is successful now, and it will continue to show you know, success in the future, hopefully, for our ability to respond.
Thank you.
Great question. Thank you.
Thank you very much for your time this morning, for all this great information, and again, helping to kind of maybe ease some of those fears that people have from listening to the media or, you know, their own concerns. We are in a break for about the next 8 minutes or so. So, you know, stretch your legs and get another cup of coffee if you need to, and we'll come back here at 10:45. Thank you. Next, we're going to hear from Dr. Thomas Cudjoe. He is a geriatrician and assistant professor in the Johns Hopkins School of Medicine. As a medical doctor who specializes in the care of older adults, Dr. Cudjoe is interested in the relationship between social connections and health outcomes in later life, and he'll share some of his research with you and also discuss some of the impact of the social isolation on older adults and how we can you know, help to reduce this isolation. Welcome, Dr. Cudjoe.
Thank you so much for the opportunity to be with you all this morning. I'll share my screen and get started. Okay. Can everyone see my slides? Thumbs up?
Yeah, it's on. Thank you.
Okay, great. And hopefully everyone can hear me well. So thank you all for the opportunity. She stated my slides, my topic, and you all can see my slides. So I'll begin. So my objectives today are to discuss the state of the evidence regarding social connections in health, as well as discuss the intersection and opportunities associated with social connection in COVID-19 and aging. And then hopefully leave a good amount of time for us to discuss this further as appropriate. So I like to begin with some literature. And it's, I have little ones, and I also often find myself spending a good time reading them stories. and stories about many different things. And a few years ago after a talk, I began asking speakers about their suggestions for children's stories. And one of the speakers shared with me this story, and it's called Little Mouse's Painting. I'm not going to read it to you all, but I think it's important to share a little bit of the content and why it's relevant here today. Little Mouse's Painting is a story about a little mouse that decides to make a painting. But when the mouse shows the painting to their friend or her friends, they have their own perspective or idea about what's in the picture. And no one listens to what Mouse has to say about what the picture is about. And so this story by Diane Wolkstein has many layers. And at its core, it celebrates the surprises of friendship and connection that Mouse has with her friends and the joy of creativity. It also offers interesting insights into the beauty of varying perspectives. And I would argue that we've had varying perspectives regarding our social connections and experience of loneliness and isolation during these times. I would say also my perspectives are largely informed by personal experiences with older adults in my life, as well as older adults who have cared for clinical care for them, as well as older adults who have engaged with during community talks. One of the ways that I often engage older adults is during clinical times. And this is a picture of our medical director for the Johns Hopkins Home-Based Medicine Program, Dr. Shookman, visiting with some of our patients. So this is, to simulate or show that we're often in the community learning about the lives and well-being of individuals, learning about how, learning about and caring for people in their context and understanding and engaging them with the people who are most often connected to them. And so I would say that it was here that I really got my first exposure to social isolation and loneliness. So I'll share with you a brief profile or vignette of a patient of mine, and I'll call her Miss B. So Miss B is a religious woman. Though she was unable to attend church when I was caring for her, she lived alone in senior housing and had minimal contact with others. She had mental and physical health issues and frequent hospitalizations. Though I noted that she really enjoyed our home visits together. And so after my visit with her, and as I was driving away, I had a variety of thoughts. But two of the thoughts that came to my mind is that Miss B's medical care was complex, but it was also impacted by the fact that she was socially isolated and lonely. These were words that I had been exposed to peripherally, but never had I really experienced the patient or engaged the patient who experienced these findings. And so I'll just, for the sake of thinking about social isolation in terms of its context with all of our social connections, I would say that Ms. B is on this lower end of the spectrum of social connection in that she's isolated and lonely. And we can juxtapose that to other individuals and their social connections. And I have a picture here of a couple that I've known for many years. And I would say that this couple is socially integrated for a variety of reasons. And so I'll come to some of these differences shortly. And so I think it's important that we acknowledge that all older adults aren't the same and that they're a heterogeneous group just like other age cohorts. And so I would say that I came to realize that social connections exist on this continuum where some have limited social connections like Ms. B and others are more integrated like the Carters. The Carters were active and they volunteered, and they always, I would say, spoke to me and my family when we were in the same apartment complex. And I would say that eventually I found out that Mr. Carter had Alzheimer's disease, but because of his wife and their connection together, he was able to maintain connection with others. And so I think it's critically important that we not only focus on deficits or absence of connections, but we also balance this with focus on assets or thinking about older adults who do have connections. There are many things to learn from both groups. And so I would say during this, my journey in learning more about the importance of social connections and health has also occurred during the time where there had, prior to the pandemic, had been increasing interest in this area, where in the public media and the national media, nationally and internationally, people identify social isolation as a public health priority. And even in the United Kingdom, they went as far as appointing a minister of loneliness. And so in our current times, we are challenged by our changes in the way we interact with others. However, we've also had the opportunity to be more thoughtful about this, as well as understand the potential that connections offer for us and learn new insights about how we might connect. In my comments so far, you might have already caught on that I've used a variety of terms. And I would say that this is one of the major challenges of this field of work, in that these various terms that I have on the screen all have distinct meanings. And these meanings have implications to various fields of study. And these meanings and terminology impact measurement and solutions.
Dr. Cujo.
Yes.
Can I interrupt for a second?
Yes.
Your audio is coming in and out, fading in and out. I'm going to make a suggestion. If you stop your camera, your audio may receive more power through the system. And let's see if that works any better.
Okay, I'll try.
Thank you.
Apologies about that. Hopefully you all can hear me better now. So for the sake of our discussion today, I want to ground our conversation in this framework of social connection. And so this framework of social connection that was published in 2018 basically describes our social connection in three ways, or groups social connection in three ways. And that is structural, functional, and quality. And so we can see here that when we talk about structural social connection, we're getting solely and directly at social isolation. Whereas when we think about function, it's more about the perceived loneliness. And then getting into quality, which is often not discussed, the quality of our connection with others. Going further, it's important to define social isolation, because I've stated it multiple times. And the way I define it is the objective lack of or limited social contact with others. And one of the ways in which we can measure social isolation is using the Lubin Social Network Scale. I point this out particularly because the Lubin Social Network Scale was developed and validated among older adults. And it's brief and has been incorporated into various surveys, as well as some electronic medical records. So what is loneliness? Loneliness is the perception of social isolation, or the subjective feeling of being lonely. We can measure loneliness using the UCLA Loneliness Scale. And this scale is brief. It's a 3-item, and it we can use it in clinical encounters as well as in the community, and it is often used in many studies. So because of its ease of use and it being rising to the top as one of the gold standards for measuring loneliness, many people have used it in their work. To go further, we can think about loneliness as a biological cue like thirst. This social craving that can result from isolation that's actual or perceived. So loneliness is like a signal that there is an essential need or a desire for belonging that isn't being met. So like hunger or thirst, it motivates people to act, and is likely that older adults might reach out to people that they are closest to when they're lonely. So in stating that loneliness is like a biological cue like thirst, we know that the pandemic challenges our desire to engage. So let's think about this metaphor a little further. We can think of this cup of water that's purified or clear as normal times and the value and benefit of consuming this good purified water. However, we know that the pandemic can be likened to this cup of unpurified water in that it may not be, or it is not proper or good for us to consume this unpurified water. And so liken it to the pandemic, we know that social interaction, connections are important for our health. And I'll show this more in evidence and frameworks, but interacting with people during these times can be harmful for us. And so it's important that we balance our interactions. So I want to stress this distinction between social isolation and loneliness here. So social isolation is objective. It's being isolated, like being in quarantine, whereas loneliness is a subjective feeling of being isolated. Social isolation, there's low levels of social contact, whereas loneliness is a mismatch between actual and desired social connections or relationships. Social isolation is not necessarily unpleasant, and in some instances, it may be possibly preferred, whereas loneliness is emotionally distressing and unpleasant. Some may choose isolation. Some may choose to be in solitude, whereas loneliness is there's some sense of a loss of sense of control or choice. So coming back to Ms. B and my journey with her and why it's important. So like I shared, I met Ms. B some years ago, and I realized that she was socially isolated and lonely. And so at this time, I began thinking of what should I do to address this problem or this concern that I had for her and that I think she expressed for herself. So I went to some of the common medical resources and I thought about my training that I had. And I really didn't come up with much at all in terms of what strategies to put in place. Finally, after, I would say after hours of searching, I came across an important article entitled From Social Integration to Health, Durkheim in the New Millennium. And just to mention, and I know you all can't see this fully, but in this important article, they kind of describe social and structural conditions and their impact on social networks and how these social networks impact psychosocial mechanisms and then into downstream factors that are pathways that impact health. And in unpacking all these different pathways, we in our current state know that a variety of impacts are noted among people who are isolated or lonely. Going further in talking about the importance of this work, I think it's important to mention who Durkheim is. Emil Durkheim is a prominent historical scholar from France who essentially founded the field of sociology. And one of his major works in translation to English is Suicide. It's entitled Suicide. And this work is important because in it, Durkheim shows that social integration influences suicide levels. And he used data from multiple European countries. His work challenges us to understand how the patterning of one of the most psychologically intimate and on the surface individual acts rests not upon psychological foundations, but upon social factors. A more recent example that I would say during the time that I was journeying to my understanding about this topic, I was in the national media and literature. Anne Case and Nobel laureate Angus Deaton published their work on deaths of despair. And they showed in this work that is of particular note that white non-Hispanic individuals in recent decades had higher levels of mortality than their peers in other nations throughout the world. And so there are some parallels between these deaths of despair and this isolation that I think we're increasingly learning more about over time. Going back in time, I think it's important to note about this other work that looked at social relationships and health and using international data to show that individuals who had higher levels of social integration had lower age-adjusted mortality across multiple studies. And in this work, they conclude and offer further thoughts that social relationships or the relative lack thereof constitutes a major risk factor for health, rivaling the well-established health risk factors such as cigarette smoking, blood pressure, blood lipids, obesity, and physical activity. More recent studies have shown by a colleague, Julianne Hunt-Lundstedt, did a meta-analysis where she looked at 148 studies with over 300,000 individuals. And in this work, she found that social connection, or individuals who had social connection, had a 50% higher levels of increased survival. She went on to do another meta-analysis that included 70 studies and 3.4 million participants. And this work showed that individuals who were lonely, socially isolated, and living alone had, you can see, more than 25% likelihood of death than people who didn't. The same researcher went on in another study to compare how social connection impact mortality relative to other important factors that we think about are important for our health. This is a complicated figure but I just want to show it because the bars in yellow are factors that are relating to social connections. And we see on the x-axis that things that are further to the right or longer have a bigger impact on reducing mortality. So we can see some of these blue bars here that interventions that encourage smoking cessation, their impact on mortality. We can see here also interventions that encourage alcohol cessation versus overconsumption, its impact on mortality, as well as things like obesity, air pollution, physical inactivity, and even the flu vaccine. So we can see here that considerations for social connections have a profound impact on our survival. So the conclusions from this mortality evidence is that the effect of social connections is robust relative to other important risk factors for health, and that this effect is consistent across gender, health status, cause of death, and country of origin. And it's also important to note that objective and subjective indicators of social connection predict risk. I've talked a great deal about mortality, and I want you to know that I think we want to do more than just prevent mortality. We want to prevent morbidity. And so I'll share a few things about some of the impacts of social isolation on other outcomes. So we know that socially isolated older adults have more than 3 times the risk of depression, they're 2 times as likely to develop cognitive impairment, and that there are higher levels of Medicare spending for these individuals as well. From my own work on a cohort of heart failure patients, we identified that the individuals who were to live with this comorbidity of heart failure and that were socially isolated had higher risk for death, hospitalization, and ED visits. We've also found that individuals who are socially isolated have lower levels of advanced care planning and are more likely to become homebound over time. So you may be asking me, how does social isolation, how does social connection impact health? And so in this recent model for direct and indirect pathways, it shows that social connections influence morbidity and mortality through behavioral pathways, biological pathways, and psychological pathways. And that these different factors feed back and create more risk for social connection or disconnection. So this work, I think many people may think that it's new, but our thoughts on the importance of social connections go back as far as Durkheim and as far as Darwin. And so I'll just share this brief quote from Charles Darwin's Expressions of Emotions in Man and Animals. He wrote here that my father told me of a careful observer who certainly had heart disease and died from it, and who positively stated that his pulse was habitually irregular to an extreme degree, yet to his great disappointment, it invariably became regular as soon as my father entered the room. So the quote, the statement is essentially saying that this person was in distress, having palpitations to some degree, and when someone entered the room, this symptom dissipated, acknowledging at that time some role of the value of connection or the impact of connection. So as my work has progressed, I began to identify that we didn't have a great understanding of how many individuals were burdened by social isolation. So I sought to understand how many people have been impacted or are impacted by social isolation. So I used data from the National Health and Aging Trend Study, which is a large cohort study that is interested in understanding the functional trajectories and health of older adults in the United States. And I found that approximately 1 in 4 older adults were socially isolated. And of this group, about 4% were severely isolated, as I characterized it in this study. And these individuals live alone. They don't talk to people about important things. They don't engage in religious or group activities. And they don't participate in their community at large. I also found that individuals who are unmarried, male, with low education and low income were also at highest risk. But we know that it's not only older adults who are at risk for social isolation. We see during this pandemic that many other groups have experienced isolation. And we know that individuals who are low income, individuals, as I've stated, that live alone, immigrant groups, the LGBTQ plus groups, as well as individuals with functional and sensory deficits or language differences. These all pose an important risk. And so in thinking about some of the risk and protective factors for social isolation, we can think about a few different things that are important as we try to identify and support individuals who may be at risk. And so I'll go through a few of these here. So physical health factors we know impact social isolation, specifically thinking about chronic diseases or geriatric syndromes or sensory impairment, as I previously mentioned. We also know that psychological, psychiatric, and cognitive factors are important, thinking specifically about anxiety, depression, cognitive impairment, and dementia, as well as personality. I alluded to personality earlier when noting that there may be some preferences for being isolated. And so it's important to note that despite that preference, there still may be risk associated with being isolated. There's also environmental factors such as transportation, neighborhood walkability, specific type of housing, geographic location, as well as, and we're seeing it more now, is the importance of internet access and access to certain technologies impact one's risk or may protect someone from social isolation. We also know that there's social and cultural factors that may be cause risk or may be protective for social isolation, and this may be individual social support, family, marital status. And going further with this, we know about geographic migration and the rates of divorce and this impact on social isolation. The interaction with friends, neighbors, and caregivers, as well as social or religious groups. We also know that disruptive life events can also impact individuals' connection and their risk for social isolation. Particularly in thinking about the loss of a loved one and how that impacts individual and their social connections. We also know that work is an important part of our lives, and that at retirement, there can be a big loss of people who are part of an individual's network and its impact on people's risk for social isolation. And we all know our current COVID coronavirus pandemic has disrupted our lives and impacted how we interact. So in thinking further about COVID, you may have heard people use this metaphor that we can come together because we're all in this together, or we're all in the same boat. I would say this metaphor has some flaw because we know about the societal inequity that exists, and that this extreme example of this large yacht is what some existence is like. Maybe this is a more appropriate example, but my point is that there is difference that exists between individuals who are navigating these waters, in some instances treacherous, with a rowboat versus a motorized boat. Maybe a more appropriate metaphor is that we are all in the same storm, and depending upon our circumstances, many may experience it differently. Thus, COVID-19 and social isolation is not experienced in the same way. So coming back to Ms. B, Ms. B is navigating this pandemic in a different way than I'm navigating, or maybe some of you. And her social isolation is more pronounced due to the pandemic. In consideration of the stay-at-home order that we went through at a period of time, her intention to follow public health guidelines, her increased anxiety about going out, new transportation challenges in terms of concern about getting on an MTA shuttle or public transportation, senior center closures, and also greater distance and inability to connect with friends or family. I also like to point out that this changing world that we live in, and trying to remind us of where we have been over the last year. This is a small graphic from the Kaiser Family Foundation, but on March 30th of 2020 is when our governor instituted or mandated a stay-at-home order. It was soon thereafter that many senior centers began to close, and then school closures, and that we realized that we were in a pandemic. In this changing world, we know that older adults are particularly burdened by the coronavirus, and that it has placed particular burden on older adults. We know data from the CDC suggests that 8 out of 10 COVID-19 deaths that were reported have been in individuals 65 or older. We also know, and I think it's important to mention, that certain race and ethnic groups are experiencing increased burden amid this pandemic. We know that rates for cases, hospitalization, and death are higher in these different racial and ethnic groups noted here. I would say that prior to the pandemic, I would argue with you and suggest that the best way to address social isolation is by providing in-person connection. However, now I'm challenged in this because we've had to address social isolation with connection at a distance. And I think that we are developing and creating new and innovative ways to interact with one another. And I'm encouraged by this. I shared this slide before, but I want to also offer that solutions may be in plain sight by addressing physical health risk factors that are a risk for social isolation, addressing psychological, psychiatric, and cognitive factors, as well as social and cultural factors that may exist, or environmental factors that impact individuals. These are all opportunities for us to think about how we can address the challenges of social isolation. I would say we also are fortunate because some of the work had been done in terms of understanding the importance of this area with the National Academies of Sciences, Engineering, and Medicine report that was published in early 2020. In this work, there's a call to develop a more robust evidence base in this area to translate what we currently know into actual practice to improve awareness about social isolation and loneliness, as well as strengthen ongoing education and training. Here today, there's an opportunity for this, as well as strengthen the ties between healthcare systems and community-based networks and resources. If you haven't seen this document, I encourage you to Google it, to search online for it. There's nice summaries of it, and I think it can be helpful for all of our practices. In thinking further about the opportunities, I think about a public health approach in terms of primary and secondary prevention. And so when I think about primary prevention of social isolation and loneliness, I think about identifying patients at risk for loneliness and isolation. So trying to target people who are at risk, who aren't isolated and lonely, and trying to address that. And then secondary prevention, thinking about decreasing the consequences for those who are lonely and isolated already. And so this requires us to do screening. It requires us to be more aware of this problem. It requires us to increase education on this issue. And I think one of the ways that we can do this is by using some of the Institute of Medicine social and behavioral domains and measures. I know you can't see this, but I think it's important to note that in 2015, the Institute of Medicine, or now the National Academies of Sciences, Engineering, and Medicine, had published a report that focused on how we can adapt social and behavioral domains and measures into electronic health records. And I think that this is one opportunity that we have. And so one of the specific areas or domains that the National Academies encouraged us to include is social connection and isolation. And the questions that they recommended are pulled almost directly from the Berkman-Syme Network Index. This index was used in the 1970s in Alameda County and was some of the original work that showed the link between social connections and mortality. I'm coming to the end, and I just want to share some of the challenges for research and public health. I've kind of stated about the conflation of social isolation and loneliness with other important and related concepts. I think we're challenged by great attention given to the deficits or the absence of connections without appropriate attention to the assets that many individuals have in their lives. The variability in terminology, measures, and outcomes of interest also challenge this work. Limited research on at-risk groups. Also, the quality of the intervention literature and work that is often being done but unevaluated in our communities and at our institutions. Also, a big unexplored area is the role of technology on all of this. I'd also note there are challenges amid our current pandemic in that there's been a transformation in how we interact. I think our initial hopes of temporary restrictions have been constantly tested. The physical distancing and stay-at-home orders that have occurred. Our impact on social and religious gatherings have challenged us. Visitation policies at hospitals, nursing facilities, and senior housing. Forced retirement, unfortunately, due to the economic constraints that have occurred, have forced people into a way of life that wasn't expected. How we've coped and also our grief processes have been challenged by all of this. And there are residual impacts that we have yet to begin to understand. Despite this, I would say that there are opportunities here. There's opportunities for the awareness of social isolation and loneliness on our health. There's opportunities because we have seen communities come together to help one another. We have seen an alignment of resources for community care and scientific advancement. We've also seen technology move forward in so many ways. The advent and the implementation of telemedicine, as well as virtual interactions and content. Also, this pandemic hopefully has given us time. Hopefully we've had the time and opportunity to pay more particular attention to important areas like social isolation, as well as attention to the people in our lives and thinking about ways that we can support one another more meaningfully. So in thinking about the way forward, I think focusing on social isolation and loneliness and other important social determinants of health are critically important. Thinking about equity and how many people experience things differently and how we can support people with provide people with the supports that they need to overcome their challenges. Thinking about policy strategies to address and understand these challenges, aligning public and private efforts to target social isolation, to continue to connect meaningfully with those in our lives, and to begin starting proximal with the people who are close to us, and then think about extending beyond. I would say that I'm also encouraged in thinking about the opportunities that exist ahead. And I'm encouraged by this tweet from a few weeks ago. It's from the Ministry of Health in New Zealand. And I share this because it's a tweet, and I'll read it, that it says, "There are no new cases of COVID-19 to report in New Zealand. There are no cases of managed isolation facilities and no new cases in the community." If you know New Zealand, it's a starkly different country than us, but it's a country of around 4.5 million individuals. And it's parallel to Maryland. Maryland is around 6 million. But to see this, I felt was encouraging. So I think it's important that we work together to move this and other important areas forward. And so in conclusion, I'd like to acknowledge my mentors, colleagues, and funders, and leave you and hopefully make my high school British literature teacher proud by sharing the words of John Donne's Meditation 17. "No man is an island, entire of itself. Every man is a piece of the continent, a part of the main." Thank you so much for your time.
Hey, thank you very much. I'm getting a little bit.
I hope the audio got better. Okay. Is it okay now?
Yeah, I don't know if this is on your end, but I'm getting bounce back. Let me take off my. Is that any better?
Can you hear me okay?
I can hear you. Can you hear me?
I can hear you fine.
Okay, I'm getting the bounce back on my side.
Okay, I'm gonna turn my camera off.
Okay,
Is that better?
let's try that. Is that? Yep, I think that is.
Okay, I'm sorry, all the participants.
Well, thank you. Yeah, no, this is definitely on my side. I'm getting a bounce back on my side. So don't know what's going on with that. But thank you, Dr. Chen. Your presentation really did highlight the importance of understanding the biopsychosocial spiritual interactions for personal well-being. So it was really nice to see some of that research that has gone into that. You know, it really should help us as listeners to think about how we always try to treat the symptom, right? We go to the doctor and, you know, we have the high blood pressure, we have the, you know, the heart disease, we have the whatever, but we need to dig a little deeper than that. We need to look at those biopsychosocial influences and not just treat the symptom. But as you mentioned, this is a risk for suicide. This is a risk for early mortality from all causes. And I know from the literature in dementia and Alzheimer's disease that social isolation and loneliness is also one of the primary risk factors for dementia, onset of dementia in older adults. So we really have to begin to unravel these complex interactions that constitute these physiological aging processes, these psychological manifestations of individual adaptation, as well as the importance of these social and even the spiritual relationships in order to help older adults to age optimally. So I truly appreciated your presentation. And looking at the chat box here, I see a lot of people saying thank you, and Allison Robinson says excellent presentation. So I applaud you as well. Thank you for sharing this with us. We do have some questions in here. We have someone from, I've got to go up just a little bit. Edwina. Edwina works for the Frederick County, she works in Frederick County and lives in a senior apartment building And she's wondering if you are aware of any new programs to deal with social activities and isolation evaluations in senior buildings.
Yeah, so Edwina, it'd be great to talk to you more. This is squarely where my focus is, particularly on older adults who live in congregate setting. I am aware. You're static?
You're good. You're good.
I'm fine. Okay. I am aware of some solutions that are out there. I will say that if you read the National Academies of Sciences, Engineering, and Medicine report, you'll note that that the evidence is somewhat weak for existing intervention. So the things that I am aware of have not been rigorously evaluated. But if you do go online, you can look up Hotel Oakland Village, which is a community that is a subsidized housing setting that they have come up with various programs to support older adults in these low-income congregate settings. Another example from the West Coast is this program called Engage that uses arts curriculum to bring older adults together. And there's many other examples, but I will say that from the most recent review, and none of these interventions have been evaluated to the point where they've been, where it suggests that they actually address older adult isolation and loneliness. So I think if you have ideas, I would love to talk to you more about this, and I can put my email in the chat.
Thank you. Jan would like to know how to get, if it's possible, to share where the assessment questionnaire that you talked about. So I think that was the Lubin Social Network Scale, as well as the UCLA Loneliness Scale.
Yes, I'll pull links and put them in the chat if that's helpful. But you also can Google Lubin Social Network Scale. A site from Boston, I think Boston University or Boston College comes up. James Lubin is a prominent social work researcher, and he developed that scale. And then the UCLA Loneliness Scale developed by individuals at UCLA. That's available. These things are available pretty easily online, and there are also other measures that I think, thinking about your setting, if it's appropriate to use in the National Academies report, which is also free online.
All right. Just trying to go through my chat box. Got pretty full pretty quick, so I'm just trying to differentiate between people who are telling you thank you, an excellent presentation from the questions. Well, while I'm sifting through this, what about, so many older adults aren't familiar with technology, don't have access, if we're thinking about lower income communities, West Baltimore comes to mind, and lack of access to the technology to remain connected. What are some other options that way that you've seen, any innovations that you've seen to help people stay connected?
Yeah, I think that, I recently became familiar with some of the work that University of Maryland was doing with and I think the Deutsch Foundation supported, along with Project Waves, is what it's called, with creating more access to internet. I think that's critically important during these times where we're encouraging virtual connections, not only for pleasure and joy in people's lives, but also connection with people's healthcare providers as well. I think that internet access, as well as technologies that are understandable, accessible, are important. I think technology is increasingly becoming more ease, creating more ease for access, where it's a simple touch to get access to certain things. I know in my own care of individuals, the technologies that have been incorporated into our electronic health records, where we can be in their patient's chart and in real time send them a link to their phone and they click on their phone if they have a smart device, and the video encounter pops up. I think early in our pandemic, when telemedicine was rolled out, there was a download of software and application, and those things all create barriers for people's use of technology. And so I think that with increased advocacy, increased encouragement of some of the technologic groups, they will create greater access for older adults and individuals with other disabilities to access these technologies. And then for lower income groups, I think, as mentioned previously, community advocacy, I think, is important for bringing up this important discussion of internet access. When we think about our urban setting, oftentimes, but individuals in rural settings, it's stark in terms of if you drive across the country now and try to use your GPS, there's many areas where you'll have to use the old-fashioned maps because your GPS or there's no cellular signal in certain areas. So think about individuals in some of these contexts. I think it encourages us to always be advocating or advocate more for digital, addressing the digital divide that does exist in urban and rural settings.
Right. Yeah. And I'm really happy that you mentioned the rural settings because, yeah, they have their unique set of problems out there, including access even to telemedicine. And one of the questions I had, even from your expertise as a geriatrician, how is loneliness? Is loneliness actually being assessed as part of, that general exam, that annual exam that older adults, perhaps you as a geriatrician, but what about internists? Are they doing any type of loneliness assessments? Are you aware of?
I know in our health system, we have incorporated these social determinants into our electronic health record. And so I think, as I tried to share in the National Academy's report of encouraging these social and behavioral domains as being a part of the assessment. I do know that there are efforts underway at the Center for Medicare and Medicaid Services to begin thinking about domains as important matrices for payment. And so I think policy changes such as this will encourage healthcare institutions to be more thoughtful about measuring these things, but also be more thoughtful about what solutions can be developed to address them. I think one of the concerns of many healthcare practitioners and practitioners in general is that, we measure, we identify, and then what do we do? So I think that's one of the challenges that exists, having good solutions, good interventions that actually do something to address this important problem.
Right.
Opportunity there. And so that, I think being the practitioners here, people, you may have the solution. You may be doing it already, but disseminating and learning more about that, I think is critically important to advance this work.
We have a couple of minutes left, and I'm just wondering, so we've talked a lot about more of the independent living and the impact on older adults who do live in their own homes, in their own communities. What have you seen, or what have you seen even in the research about those people who are living in residential communities? So the nursing homes, the assisted living, whose families haven't been able to really come in and visit.
Yeah, this is very interesting work, and I think the verdict is still out in terms of what has been the actual impact of the coronavirus pandemic on the health and well-being of older adults in community and in congregate settings. And so, historically or at baseline, you would think that individuals who are in some of these congregate settings they may be the potential to be more connected and less likely to be isolated. But that's challenged by some of the strains that may exist in those settings. you might think readily about subsidized housing settings, like mentioned earlier. Some of those settings are oftentimes in high crime environments, and there's a variety of other social circumstances that impact those settings. And thinking also about nursing facilities or assisted living, some of these, there's variability in so many different things that exist in some of these settings. And I would say that there are, many opportunities for us to think about solutions going forward. Of course, the pandemic and the restrictions with visitation policies have had an impact on people in their connection. And I think some organizations have creatively figured out ways that hopefully I didn't breeze through it too fast, but one of the pictures that I showed was an older adult being able to connect at a distance on like a screen porch with their loved one. And I think those type of innovations and interventions are important. And I think that we have to be advocating for these things for our family members, for our friends, and for individuals in our community. I think it's critically important to be holding these organizations accountable to doing something to support this important aspect of people's lives. Also mentioned in thinking about the impact of the pandemic on older adults, there's been some work, and I wish I had the citation here to share, but about the impact of social isolation and loneliness on older adults, in thinking that older adults in some instances have lived long lives and have potentially experienced levels of isolation in the past, and so that there may have been some resiliency factors that have developed over time that in some instances prepared them for the anxiety and stress of it, whereas some younger groups have not experienced it and may be more strained by these current circumstances. So I think we'll have to see the impact over time on how did these change the health and well-being and connections of older adults comparatively to other age groups.
Yeah, I have been really heartened by some of the young people that have come to me. So my research interest also is in social isolation. As a gerontologist and a professor, I had a group of students reach out to me from the University of Pittsburgh from the physics department, who were thinking in terms of older adults in the community, their own grandparents, thinking about how they weren't able to connect with their grandparents and what type of technology exists as a class project, their capstone project. They were tasked with developing something. And our discussions really led to, this isn't just pandemic. This is happening, across our country, across our communities, in skilled nursing, in assisted living, in independent living. And it really opened their eyes, and I was able to connect them really with a great group of researchers down at the University of South Florida who's been doing a lot of research on this. Yeah. So there's some really cool tools that are already being developed, and these great young minds who now have an interest in this because their eyes have been opened as a result of COVID. But you're absolutely right. When we think about the resiliency, I've seen a lot of data coming out on resiliency compared to the younger groups that hasn't had the same trials and tribulations of life that helped prepare them for this. And related to that, we do have a question from Lee Newcomb. And Dr. Chen, I see possibly that you're still on, so you may want to provide some input here also. But she is wondering if there's been any research or planned research on the indirect COVID deaths. For example, patients that were not provided with adequate testing, treatment because of COVID. And along those lines also, has vaccine development in other areas, thinking about Alzheimer's research, for example, has that been halted as a result of the vaccine, the quickness of our vaccine development now?
Yeah, good question. I don't know about those other research activities. I know a lot of academia has kind of coalesced around trying to corral their expertise to try to respond to COVID-19. So I do imagine that non-COVID research remains unaddressed. And so I suspect that that's probably true, but I can't really confirm that with real numbers.
Yeah, empirically, I'm not aware of anyone who's directly looked at this, but I know in my own work, community-based work has largely been stalled because, or been adapted to using technology to accomplish it. So that's research. But in terms of thinking directly about cause of death, I have not seen work on that. I know that in the first surge of the pandemic, clinically, I would say that our health system and other health systems experience fewer people presenting with the heart failure exacerbation, COPD exacerbation, these common chronic medical exacerbations because of concerns, I think, with coming into these healthcare settings and COVID risk. But now I think during this current surge, those levels have not, in my own institution, have not necessarily gone down. And so that's where we see further strains on the health system and trying to balance the care of people with things that were already going on with the coronavirus infection rate for inpatient care.
Okay, well, thank you. I think we are at time, so I think Joy is going to come back on. Last comment that I'm seeing in the box is obviously thank you, Dr. Cujo, to Dr. Chen for Deputy Secretary Hutchinson. And this person writes, we don't have the name of the person, but she says that even if others don't care about the topic, I know that she knows that she's going to get out there and start really looking at this also. So you with your social isolation, loneliness, the ill effects that it can have on our health and our well-being and increased early mortality rates, I think you really stimulated some good thoughts in people. Yeah, just lots of thank yous coming in, so you can take a look through the chat box for that. Thank you very much, everyone.
Thank you so much. Appreciate the opportunity.
Thank you to our wonderful speakers today, Dr. Cujo, Dr. Chen, Deputy Secretary Hutchinson. You were all so engaging and informative. Thank you to Dr. Martin for her terrific moderating of today's conference also. And thank you to our participants for attending today. As I explained earlier, please complete the evaluation. This feedback is so valuable to us. The link will pop up when you log out, but it will also be emailed to you as well. We will send the slides and the resources that have been included in the chat box to you by email along with your certificates. Thank you again. Have a wonderful rest of your day.